experience. And after that, we will have lunch.
We predicted won't take too terribly long. So again, my name is Sarah Jameson. I am the stroke program manager at OHSU. So I manage primarily the processes around the various aspects of our stroke program. So I'm going to be talking more about OHSU's experience with our Telestroke program, specifically our acute Telestroke program. So if you haven't had the opportunity to travel to OHSU or see other pictures, this is a picture of our hospital. And the building, the brown building to the left, that is, on top of that building is our helipad. In addition, you can see it's located up on a hill. We do have very limited vehicle access to our campus. So that includes for patients and for ambulances. OHSU is a comprehensive stroke center, and it is one of 4 comprehensive stroke centers in the Portland area. So with a high density of stroke services for our area, in addition to some barriers to access for patients by ambulance or by private vehicle, we really do rely very heavily on our transfer population to bring patients with stroke to our center.
Not to the cable car.
Yeah, they don't ride on that. If you ever get a chance to visit, though, I recommend that you ride on it. So this is just representing our distribution of how our patients arrive to OHSU. The darker bars represent our patients arriving to OHSU through the emergency department, so by ambulance or by private vehicle. And the light represents all the patients coming to us via transfer. And this is a distribution by quarter. And so far in 2023, we've received about 63 to 64% of our patients via transfer. So kind of looking back at some of the history of our stroke center at OHSU, we started our Telestroke program in 2010. And I also have highlighted here we were the first in the U.S. to transition to tenecteplase for stroke treatment in 2019. So an overview of our Telestroke program. We provide video consult services for acute ischemic stroke patients. This allows access throughout Oregon and Southwest Washington to stroke specialists. We conduct both phone consults as well as Telestroke, meaning the video consults. And as a component of our program, we do have 24/7 neurointerventional coverage. This is somewhat unique in the Portland area. Other services split between the cardiac cath lab and neurointerventionalists. OHSU has dedicated neurointerventionalists. Since 2010, we have done over 3,000 telemedicine consults, and we have approximately 1,200 telephone consults per year. So not all of those telephone consults transition into telemedicine consults. Our team, this is only for telemedicine coverage, which is provided 24/7. We have 2 full-time attending strokeologists, Dr. Larson being one of them. We do have 1 stroke fellow, and then we have 3 part-time strokeologists that kind of fill in, help out where they can. So this is a representation of Oregon and parts of Washington. So we're at the hub here in Portland. And excuse me, we have, this represents all of our telemedicine sites. We have 15 total sites in Oregon and Washington. And our, excuse me, our sites do vary in size. We have a large number of rural sites. So this includes hospitals that have fewer than 30 beds and are greater than 30 miles from any other hospital. So they have limited resources. Our furthest Telestroke site is located 221 miles or 355 kilometers away from OHSU. In addition to our Telestroke services, OHSU does offer access to other specialties through this program, to include our telepediatric ICU, our teleneonatal ICU, our telepediatric diabetes, and then our most recently our tele ICU services. So the purpose of our program is primarily to avoid costs associated with transportation when transportation can be avoided, as well as to keep patients in their local communities if possible. This keeps patients closer to their support systems and families, which makes that care and transition out of the hospital much more seamless. And approximately 60% of our Telestroke consults are able to remain in the local community. So this just represents our Telestroke consult volume since 2010. And you can see that we have also had experienced the impact of COVID. So we did have a drop, and since that time, we've been steadily increasing our volume. Since in 2023, we have already exceeded our 2022 volume. That could be in part because we did add a few new, very small sites, but we did add sites this year. So this again represents our volumes, our Telestroke volumes, and this is by month through October of this year. You can see that the volumes do vary month to month, and these numbers only represent the consults that utilize the video component. Does not include the telephone calls that we receive in addition to this. And so our video consult is only used for about 25% of our total consult volume. So there are far more consults than actually require video. So this represents our percentage of Telestroke consults that are transferred to OHSU by quarter between 2021 and quarter 3 of 2023. This is just to provide that visual of how many consults to transfers that we're doing. And this is partially impacted, a little bit different in our area. We have limited beds and we struggle with capacity quite frequently. So we have had to turn down consults or transfers on occasion. We try to avoid that, especially for our thrombectomy candidates. We do always try to reserve a bed for those patients, but other patients we may have to help support at the outside facility, or they'll find a different center to transfer to. So moving on to some interventions that we're able to do with our Telestroke, our acute Telestroke program, we often give thrombolytics over Telestroke. This represents our volumes. The first set represents our total volume of thrombolytic administration. So we've had 107 so far in 2023. But you can see on the next grouping that we've only done 16 at OHSU. So we do have limited patients arriving within that window and appropriate for thrombolytics at OHSU. Majority of our administrations come in what we term the give and go. So as I had mentioned, we transitioned to Connect to Place in 2019, and one of our previous stroke neurologists coined the term give and go instead of drip and ship because Tenecteplase is given over a bolus. So it's just a one-time administration, and then the patient is packaged up and transferred to OHSU. We also have a large percentage of the give and keep. So we are administering thrombolytics over Telestroke, and those patients are able to remain in the local facility. There are likely a small proportion of these patients that are having to transfer to another hospital if the referring institution doesn't have the resources to keep a patient for that post-thrombolytic care. And then in terms of thrombectomy, that's one of the services that we offer with transferring patients to OHSU. We often do bring them in for consideration of thrombectomy. So this represents our total number of Telestroke consults that transfer and receive thrombectomy. And depending on where the patient is coming from and what imaging has already been completed at the referring hospital, sometimes we will repeat imaging when they arrive at OHSU. And sometimes on that repeat imaging, we determine that the patient is no longer a candidate for thrombectomy, in which case they would proceed to the ICU. So that's a component of why all the patients that we're transferring for consideration of thrombectomy are not going to thrombectomy. In addition, some of these patients are just transferring for that higher level of care. So post-thrombolytic therapy or edema watch. So I apologize, this is kind of small, but this is our Telestroke process. This is the algorithm. And basically, the referring hospitals call into our transfer center, so a central location. We have triage nurses there that help to triage. If the patient is known to have a hemorrhage, they'll be triaged to our neurosurgery colleagues. But if the patient is thought to have an ischemic stroke, if they haven't done any imaging yet, then they'll be triaged to our acute stroke team. We do recommend that CT, CTA, head and neck is completed prior to activating our Telestroke consult service by the referring institution. So in most cases, they are already calling and that imaging has been completed. So at that point, the physician gets on the phone and talks with the referring provider. If the patient is likely to be a candidate for intervention, whether that be thrombolytic therapy or possible thrombectomy, then the consult transitions to the video component, and then the provider is able to interact with the patient, examine the patient, and also talk with the referring physician, the team there, and the patient's family if present. Actually, before I move on, any questions about our process there?
So I see you in the bottom of the slide, you see like you have applicable content review facts, right? The consent, I mean, like, sorry, right? You track the consent and decide the consent.
Yes.
And the doctor on both sides talk together.
There's two consents. We do have a consent for Telestroke consult, so the referring institution gets that consent before or during the process of this consult. It's not delayed for that consent part. And then consent for thrombolytics is done over video typically by our providers. Because the referring is the administering physician, they also get consent, verbal consent from the patient.
I mean, if some complication happen, and then who will be discussed with the patient, if the thrombolytic patient gets some bleeding or?
Yeah, that's a good question. My understanding, and maybe Rachel, you can clarify, is it is the administering provider. We are giving our recommendations. So we're the consulting service, and they are still the primary.
So they will decide by themselves, or mostly they follow the, right?
Yeah. I don't know that we've ever had a case where they've elected to not give thrombolytics, even though we've recommended it. If the family, if the patient prefers not to escalate therapy, then that might be an indication to not give it.
And the quality of the picture that you see from the Telestroke compared to the you see from the
I can
phone.
show you after.
Yeah, I'll show you.
I actually have a picture too, but yes, very, very
You
good.
use some application or some software, right?
Yeah, there's each of the sites have a telestroke or a tele station. So it has a camera. You guys control the camera, right? Yeah, so they have a remote control of the camera.
So who will test the physical examination at the primary hospital to test about the NIH and evaluate that?
Yeah.
Who will do that? Doctor that? Is a ER physician or a neurologist or what?
Yeah, so like Dr. Larson would be doing that exam on the patient.
Yeah.
Obviously, it requires interaction from the patient, and if they're not able to follow commands, it doesn't happen all the time, but we do have in our guidelines for the referring to have a nurse or someone in the room to help administer the exam. That's really important. It doesn't provide a lot of information if you can't get certain components of the exam if you're just in there with the patient who isn't able to communicate. So that is a component, and I'll get to some of that too. We have a checklist for our sites of things that they are responsible for and that they need to do to make this successful.
I think that from Spoke Hospital and Hub Hospital, for Spoke Hospital you have the ED or the GP to test, and they have the background to test the NH score before that, right? How to use the camera. I think you use the Korean company. I think the what is the company that use the hardware? I think at the time
an RP light system. I don't know.
I think the same as we have 10 years ago.
Oh.
I remember. I think the same company.
Oh, okay.
The FDA approved. I think yes, maybe this come from. It's a new one. Tele is new brand. มันเป็นแบรนด์ใหม่ของเกาหลีอ่ะ
มันมีวิดีโอนี้ป่ะคะ
มันจะมีวิดีโอด้วยแล้วเทเลยฝั่งนู้นแต่ฝั่งสะโพกมันจะมีหมอมีหมอมีพยาบาล
like video conference
So it's very clear that the camera is very okay to check the pupils, to check the facial grouping, something like that. And you can move the zooming to the camera in the slope side.
Yeah, they just sit at the end of the bed and then they can take over control.
Yeah.
เขาใช้ซอฟต์แวร์แบบไหนนะที่ใช้กันเนี่ย stroke
ไอตัวของที่เดียวกับที่ซันดูเคยใช้อ่ะไม่แน่ใจ not sure
เขาทำ
I'm not sure in Thailand we have a mobile stroke unit in the car in the mobile stroke we have a like camera that link the picture to the Telestroke hub and they can control but I'm not sure about the software is the same that you use in mobile stroke unit and for consultation is it the same in the United States?
To use these teledocs, they have everything inside, like
CT.
for the picture, CT.
Yeah, the program.
I'll
CT.
talk a little bit about that. So as soon as our referring site even thinks that they may want to consult for stroke service, we ask that they push images to us. We have a system to push images. It does take some time. The CTA in particular is a very large file and it takes a long time to receive. So that's been a barrier for us and something that we've been trying to work on and come up with solutions. OHSU was actually looking at a new imaging system to make that transfer of images faster because there are some delays.
If the hospital to hospital, I mean doctor anywhere, doctor on the station in the hospital, right?
It's only in the emergency department and only sites that have the robot, the
จุดไหน
Telestroke
ไม่
part of their
อัน
site.
ละปิดอ่ะ
And we have a contract with them to provide medical services. So they have to be credentialed and privileged at each of our sites before being able to provide those services.
So when Dr. Lawson decided to give the thrombolysis, did he see the imaging before?
Yes.
You see, oh, so that hospital sent the imaging and she evaluated that and told by the phone.
Yes.
And we have a remote system, able to get remote access to like images and the chart from home, so I can look on this computer at the images before I get.
So you can access all information like the primary hospital.
If they
drug
send it,
history.
if they send it.
Send the permission.
Yeah.
Oh, yeah.
It means you cannot access directly to the hospital computer. Cannot.
Not all.
Cannot.
Not all.
Yeah, any imaging has to be,
Have to
Push
send.
yeah, they have to push it
Oh,
over. And so it has to go through the imaging department.
We do have a couple of our partner hospitals that we share a system with, the close-in ones, but none of the further out ones, so we have to wait a little bit.
Yeah, it's usually not, I mean, if it's at the top of the list, it only technically takes about 10 minutes to do. But you have to have the person at the computer.
So you use the rapid software to design the rapid
For TPA, just CT, just the plain CT.
and you design the
And decide based on last known well, symptoms, patient preference.
no rapid.
We use it once they've arrived, and Sarah might talk a little more about kind of, once the patient arrives, we'll often repeat imaging prior to thrombectomy. So they'll have had the CT head and CTA at the outside hospital. The outside hospital calls us, tells us the story, we look at the imaging, we get on video with the patient, do an exam, give the thrombolytic, they come to us, then we evaluate for thrombectomy with rapid.
How long is your typical consultation?
The video consultation, usually I'll spend probably 2 minutes on the telephone, and then if I think it's someone who's a candidate for either lytic or thrombectomy, I'll ask them to bring the robot in the room. And that part is variable, but usually only like 2 minutes to do an exam. And then the variability comes from consent with the family, how aggressive they want to be.
So let's say 5-10 minutes.
Yeah. Pretty short, yeah.
Right.
Yeah.
It's pretty quick. Sorry, lots of interruption.
Yeah, no. Good conversation. So this is just an overview of our transfer process. So if transfer is appropriate and the patient is accepted, then the transfer center who originally took the call stays on the line throughout this process and does help to coordinate the transfer between the referring and the receiving hospitals, and also to help determine which method of transport is fastest for the patient. So we have a few different options. We can do ground, we can do rotor wing, which is very weather dependent in our area. We can also do fixed wing. We do have an airport that is about a 30-minute drive, about 29 kilometers from OHSU. As you can imagine, this takes a lot longer than the other two options. But over the years and through trial and error, we found that patients from about 70 miles away or closer, fastest is ground, and beyond that, helicopter for us. Another essential component of this is that it's our collaboration with our EMS providers. So it's really important for our EMS providers to provide ETAs for our patients, and that allows for our interventional team, our nursing team, our provider team to get to the hospital to be ready to receive the patient when they arrive. Also for them to continue to provide updates as they get closer to the hospital. Their final update is when they're 10 minutes out. So everyone will then proceed either to the helipad to receive the patient or ambulance bay to meet the patient there, depending on which way they come. So the arrival process is very well coordinated with the physician performing the telestroke consult. The physician performing the telestroke consult is the physician to meet the patient when they arrive. The stroke response nurse, neurology resident, they all meet the patient at the door, and then they proceed either to the predetermined location, which would be to repeat imaging, so straight through to CT, or to neuro ICU, or to angio. That helps EMS who are not familiar with our hospital too to navigate where to go and how to get there the fastest. Another important component is that we do not stop in the emergency department. It just takes time to stop in the emergency department, examine the patient, and then proceed on. So the exam and everything is done en route, like as we're walking through the hospital. And the only time that they would stop in the emergency department is, for airway concerns, if they need stabilization otherwise. So because of this process, just for reference, so far in 2023, our median arrival to imaging time for these patients has been 12 minutes, and our arrival to arterial access for our thrombectomy patients has been 33 minutes. This is in part related to bypassing ED, but also there's a subset of patients that we don't repeat imaging on, and we go direct to angio, so it's direct transfer. So as a part of our telestroke process, we do provide some education and follow-up. We do have regular check-ins with all of our telestroke sites. This is done every couple of months, depending on volumes at the site. In each of these check-ins, we do review cases as well as patient outcomes. So I'll put together, their NIH at discharge, what we did for them while they were here or with us, and a modified Rankin at 1 month at least. And that's just to help build those relationships with our referring sites and to demonstrate the care that we're giving to their patients. We also are able to follow up on any process or clinical questions from the team at the referring. So often we'll have the ED physicians, hospitalists if applicable, and nursing staff on these calls, and then resolve any technical issues. Technical issues we don't see many of, even with our new initiation sites, newly initiated sites. We also, just to provide that continuing education, we were providing annual in-person stroke lectures. This was paused during COVID, and we're looking at resuming these lectures, and this is just, again, an education for our referring. They also, all of our referring sites have access to our round around and other virtual continuing medical education conferences. So this is, I was just going to run through a quick case that we recently had. So the picture on the left is what it looks like from the patient side. That is an ED provider, patient in the bed. You can see that's Dr. Clark on the video, and then what it looks like, kind of, you can see from his perspective. So this was a recent patient that we had. This patient presented at a hospital which was located 74 miles from OHSU, which is about 119 kilometers. The patient arrived at a little over an hour from his last known to be well. The referring hospital had concerns for stroke and sent the patient immediately to CT for CT head and CTA head and neck. As the patient was wheeled back to his room in the ED, images were being pushed to OHSU for physician review, and the consult was called. The OHSU stroke neurologist got on the phone and determined a video consult was appropriate in this case. And prior to logging onto the video, the images were able to be reviewed, which demonstrated a right M1 occlusion. The patient was examined over telestroke video and the patient had an NIH SS of 16. The labs were reviewed, consent was obtained from the patient and his wife, and the decision was made to give thrombolytics. So the stroke neurologist instructed the referring hospital to give TNK, and TNK was pushed at 23:56, 13 minutes after telestroke consult had started. Next, OHSU's INR attending was brought on the line into the consult, and the thrombectomy procedure was explained and consent was obtained for potential thrombectomy, and the patient was then prepared for transport. So in this case, kind of on the borderline, but determined that life flight or the rotor wing was the quickest way to the hospital. And initially, the ETA was 26 minutes after midnight. This, however, was later updated to 1:12. This is not an uncommon occurrence in some of what we struggle with transport. We do often have these delays, primarily related to availability. So the patient did arrive at 1:12. Repeat exam was performed and NIH was stable at 16. Prior to the patient arriving, it was determined that the patient would go direct to angio, so did not stop in CT for repeat imaging. The INR team was waiting with anesthesiology. The patient was intubated on arrival and arterial access was attained at 1:50. TQ2B reperfusion was achieved after 2 passes at 2:11, so 59 minutes after the patient arrived. So overall, within 4 hours and 11 minutes, we had the initial telestroke consult. The patient was treated over telestroke with TNK, transported 74 miles to OHSU, and successful thrombectomy procedure was completed. Ultimately, the patient was discharged with an NIH SS of 6 and a modified Rankin score of 2. This particular patient did go to inpatient rehab. For this case, our door to groin time was 38 minutes. So some of our lessons learned and barriers. First, I'll go through lessons learned. In the beginning, the workflow is a little bit clunky and slow with the referring as they get used to the process of the number to call and setting up, bringing the robot into the room, setting that up, and transitioning from the phone to the robot component. With some practice and experience, we've found that the sites get much more efficient in this process. We found that storing the cart in an easily accessible location has contributed to decreasing the consult time and getting on video and being able to examine the patient. We've occasionally had to move the cart from one building to another, which just delays the consult and the ability for the physician to examine the patient. We've also found that prior to being initiated as a site, going through some mock codes and having the referring log on to the video or onto the robot with one of our Office of Digital Health staff has been really helpful just so they can become familiar with the operation of it. And in addition, all of our stroke fellows, which will, before they take Telestroke call, they receive training on operation of the robot as well. And as we discussed previously, if having the family present is ideal, so we can talk to them and and we can obtain consent and also history, medications, all of that for the patient. But we've asked that our referring sites, if the family is not physically present, that they can help get in contact with the family. So this is something that can be happening in the background as the consult is taking place. And in terms of some of the barriers, I previously mentioned this transfer of the imaging to OHSU is sometimes a problem. And one of the ways that we're dealing with that is to ask that our referring sites push the imaging as soon as possible. So as soon as it's completed, we ask that they push that to us, so that's available as soon as possible. We occasionally do have physicians on both ends waiting for imaging to arrive before we can proceed. And then the availability of transport, and like in the case that I previously presented, Life Flight, sometimes they have to go refuel and then they can proceed to the location, which can delay. Also with our more rural sites, only one ambulance is in the area. If you take that ambulance out of the area to transport the patient to us, that leaves no emergency medical services available for the area for that time. So one way that we're approaching this issue is we're going to start encouraging our referring sites to consider a backup plan. What other EMS agencies can they rely on and bring into the area to cover while they transport, so we can still transport the stroke patient as fast as possible. This is a checklist that we developed for our sites just to help delineate the steps needed for a successful Telestroke consult. And you can, during the consult, we really do emphasize having staff present to assist with the exams. And here's an overview of what our telemedicine program aims to accomplish. So it's developed in response to the quintuple aim of healthcare reform. So it allows specialty care independent of location, reduces costs associated with transport, as transport is not always necessary. And this is particularly important in our current state where capacity is a significant issue for us, that we're transferring the appropriate patients. So those patients that are more likely to require our services, specifically thrombectomy. So overall, our patients have reported being very satisfied with our Telestroke consults in the process. I think one of the more significant aspects is that the patients can talk to our providers through the robot, the family can talk to the providers, and the provider that is doing the Telestroke consult is also the provider to meet the patient at the door. So it really helps to create that trust. So our patients have reported being very satisfied with this service. And that is all I have. I just want to extend it as a thank you.
Thank you for very dedicated program of Telestroke. Let me ask you a few questions. First, because you are in the comprehensive stroke center, if you get more data, then you stick to the guideline. What is the target of the door to needle time? Is it 60 minutes or 30 minutes? One. Second, what is the target of door to thrombectomy?
Yeah, so our target for door to needle is 75% of our patients treated under 60 minutes and 50% treated under 45 minutes. So they have not, we're DNB certified, they have not implemented the 30-minute door to needle requirement yet. I suspect that will be coming. And in terms of which patients meet that criteria, only include our patients where thrombolytics are administered on our site. So all of our thrombolytic administrations off-site are not included in that component. That would be their data. And then in terms of door to groin, we do have a target within 90 minutes. For our OHSU arrivals, we do target a slightly higher number. So we do the 90 minutes. And then for our transfer patients, because we don't have to go through all the workup of accepting the patient, the imaging, and all those steps, our target is 60 minutes.
I'm wondering about who pays all this. I'm sure you have a lot of fixed costs, equipment, personnel on OHSU site, and also on your satellite sites. And another thing is about the payment from patients. I guess it's mainly insurance paying all this, right? But for the let's say running costs of this program, who is it OHSU?
No, not entirely. Our program is different than a lot of the other telemedicine programs in the area. We do not charge for our services. We only bill for the consults provided to patient insurance. And in terms of the equipment, we do require that our satellite centers pay the rental fee for the robot. So they're paying for that component. We'll provide the service and we bill insurance. We don't have any fees on top of that. Another institution or area does charge for having the consult service available.
You mean the charge is from the hospital or the charge for the doctor fee, or is including?
They charge the site for the consult service.
It's probably a weekly fee.
A weekly fee?
Yeah.
Oh.
เช่าที่บอกว่าเช่าบริษัทมาได้
It's
เช่า
like a fixed amount per like year or month or
I
week
see.
To offer their services to them to be available on call, but
Yeah, and there's probably additional fee if there's an actual program.
Talking about the number of thrombolysis and thrombectomy, I do six after COVID this year. We have only 5 or no more than 10 of lytic, less than 10 of thrombectomy. How could you improve your CSR? I think we have the check-in visit. How do I think you have the candidate, I mean the competition also. I think you have many hubs in Portland. How do you keep on your popularity of your stroke center?
I think it's in part due to availability of stroke neurologists like in our state. They are concentrated in Portland, but there isn't a large number, so they are referred. And OHSU, because of the barriers to patients coming up to the hospital itself, we have established the outside referral network, which includes up into Washington as well. So I think that's the primary reason, and availability of neurointerventionalists, centers able to do neurointervention. We have 5 in Portland, so 4. We have total 4 comprehensive stroke centers, which can all do neurointervention, and 1 thrombectomy capable center, which can also do neurointervention.
Yeah, and compared to, there's several Portland sites that have this, but compared to the rest of the state, the ICU capability of a specific neuro ICU is also something that we have to offer that others don't. I think also part of OHSU's reason for having the stroke consult service be available for free is to allow that relationship to be open.
by not charging for our service, it causes them to want to send us patients. They want to call us and then indirectly There's financial benefit because the patient's getting a procedure, they're getting imaging, they're getting other care at our hospital. So indirectly, it does bring in, some
So
financial
let's
benefit.
say they call and you give some advice and then that's it. You just bill them for that consultation, or is it totally free?
We don't bill for the phone advice,
Right,
only
but
if
for
it's
the
video.
tele.
Only if it's a
it is
video. And so we only do video generally if it's a lytic or thrombectomy candidate. That when we think based
I
on the
see.
phone call, we say, oh, this sounds like a large vessel, or oh, high enough NIH in 4.5 hour window. Then we get on video and we can bill, but.
Okay.
Yeah.
Wonderful. And you're very strong too, because you're running this 24/7 with 2 full-time strong neurologists.
Not entirely by choice.
Actually, I don't know.
Thank you.
It's too much to ask, but I don't know, when we also have 24-hour service, we have the on-call, so, just in-house at night time. But, we pay them for the moonlight fee, right? They stay, but I don't know, you on-call like 24-hour, dividing for 2 people and then cover for the whole year.
So
I mean, the hospital, they should support you for something, right? I mean, in your job description, then they, right?
So there's a set salary amount, and then we also, part of our contract is the telemedicine, and that's paid hourly. So the number of hours that I work, that determines like my total salary. So there's like fixed salary plus like a tele bonus based on the number of hours I work. And there's a set minimum, so I have to work 1 overnight a week and 1 weekend per month that's from, Friday afternoon to Monday morning around the clock. And that's like a minimum, but then if I work on top of that, I get paid it's all based on hours.
Are you on site or you?
Home.
Oh,
I round in the morning in person on the weekend and then come home and just take calls.
and your computer.
But you have to have your computer with you all the time, right? Even you go outside.
I don't go out, I stay.
No.
I'm too scared. Some people are brave. And
Yeah.
go
I mean, this-
Right, when you on call, right? When you on
When
call,
I'm on call, I
stay home. I
stay home with my cat.
Find another cat person.
But again, if a patient gets transferred to OHSU on that weekend, though, you would have to
I
come in.
come in.
Oh, you have to come in.
If the resident is giving thrombolytic in the ER or we're bringing a patient for thrombectomy, I come in. But it's only
stay home.
7-minute drive for me,
Oh,
so it's not.
I am very
Not so much.
Traffic's a little better in Portland.
Yeah.
When you should try Bangkok. 7 minutes is nothing. It's one traffic.
More like-
I spend 10 minutes to the restaurant.
Yeah.
I drive fast, but to the hospital, I go slow.
But you use the LabKit software, so you have an extend time window for mechanical thrombectomy, right?
We go out to 24 hours.
24 hour. Oh yeah, that's extend time. We not sure you have used LabKit for many years, right? Yeah, it's improved in both about the outcome. This does improve in the outcome of the treatment when you get the LabKit, because now in all hospitals we don't have LabKit. We cannot like really extend the time for thrombectomy. As you know, maybe sometimes we just adapt from like the Dawn criteria about the age and the NIH and try to calculate it in fact volume not more than 50 or something like that, but just estimate by the experience of the stroke specialist. But if we got the LabKit, it may be more easier. Yeah, but what do you think LabKit help you more about that?
So I've only worked in a time of having rapid, so I don't know, I can't speak as much to pre-rapid software, but I think the benefit that I see is that you can see the penumbra, the potential salvageable tissue and lineup, is that eloquent tissue? I think that's the benefit, is saying, is it an area that it's like motor strip, language area that's green, then you might be more in favor of proceeding with thrombectomy.
And for orthopedics, it take more time in interpretation or not? When you do CT
Sometimes, lately there've been some challenges with the rapid software processing times. Because it gets sent to Stanford and then sent back to us. But usually it doesn't really significantly delay it more than 5 minutes.
5 minutes. Oh, 5 minutes.
And we don't, it has nothing to do with our decision about Senectaplace. And the IR team, the interventional team, is still moving, like getting the room ready, getting everything ready. But yeah.
Do you realize that any other center they're using like MRI based or for the?
We aren't in Portland as far, I don't know all the practices of the other providers in Portland, but at our hospital, we don't use I know I have a friend at Houston who does, in certain cases, kind of like diagnostic uncertainty, if it's like maybe a patient who had a seizure and isn't recovering as quickly as expected, but still in window, they might do a rapid MRI. But I think a lot of centers are using perfusion with rapid in the States.
CT perfusion.
And in your center, use about the perfusion or the collateral to select about the patient who have benefit about the thrombectomy?
Yeah, we do take into consideration the collateral circulation, and ultimately, it's kind of a discussion between us and the neuroradiologist. We have neuro IR trained, stroke neurology trained, and neurosurgery trained. So 3 different types of interventionalists that we're working with, and I think the difference in background, different people have different opinions, perspectives.
Same here.
Hi, sorry to interrupt. Can I just ask for other side, do they have final question? Other side, any question for Sarah before we finish? มีใครมีคำถามไหมคะจากซ้าย
สายใกล้ผมบ้าง
ไปลองติดต่อโรงพยาบาลสุขุมวิทนะ
If not
แต่บ้านอื่นต้องมี
ต้องมี
หลายๆข้อ